All right, well, welcome everyone. It's good to be back. Welcome to the Radicle Community webinar. My name is Timothy Byars. I'm the president of Radicle Health, and of course, I'm joined tonight by our CEO, Eloise Theisen. The Radicle Community is comprised of advocates and educators, healthcare professionals, cannabis stakeholders, and what we intend to do is provide support and information and resources to our members. So for information about how to join the Radicle Community, you can go to our website, radiclehealthcare.com, and click on the community link. When you sign up, it gives you access to some of the back-end website stuff, but it's free to sign up. Really, all it does is it adds you to our email list so that you can stay informed about our future events. I also want to remind everyone that we have an array of curriculum options at a range of price points for students and working professionals. So whether you are helping customers make good product choices, maybe you're treating patients, maybe you might be advocating for social change, you might just be using cannabis yourself, or maybe you have a family member that you're helping to use cannabis. In any of those cases, you need evidence-based factual information about cannabis. And Radicle Health is up to date, it's comprehensive, and it's informed by both clinical experience and expertise, and also instructional design experience and expertise. So please reach out to us for information, or go to our website and click on one of the education links to access the content. So the information, the presentation today is for educational purposes only. The information presented today is not intended to be a substitute for medical advice. This information is not meant to help in the diagnosis, prognosis, or treatment of any virus, disease, illness, or condition. If you are using cannabis medicinally, please work with an experienced cannabis clinician. All right, so today we are talking about cannabis use disorder. So I'm going to turn things over to Eloise for the first half of the presentation, and then I'll come back on, and then we'll have some time at the end of the hour for questions and comments. Eloise, take it away.
Thank you, Timothy. Well, welcome everyone. It's so good to see some familiar faces and names. It feels like it's been a while. So excited to be able to present again for everyone. And I just want to kind of start out by saying, I know that this can be a very divisive, polarizing topic, and it may bring up some emotions for some people. And hopefully you'll see here that we really are trying to present the information in a way to highlight the challenges that we see with this diagnosis, and some of the work that we hope will change, and just again, try to get a different perspective about it. I know it's a topic that we've had some fun, I guess. I don't know if that's the right word, Timothy, researching and putting this presentation together. So we're really excited to present this information, and we welcome any kind of questions or comments that people may have. If you want to put it in the chat, or just wait till the end, like Tim said, we will open it up. So let's just start. What is the definition that's currently being used? Cannabis use disorder. We also will hear it termed marijuana use disorder, marijuana addiction, cannabis addiction. The diagnosis made from the DSM-5 criteria is often diagnosed in problematic users, and the cannabis user continues to use cannabis despite the negative impact on physiological, social, and physical functioning. Slide, please. Cannabis use disorder prevalence. I think this is definitely up for debate as well, because right now, my biggest challenge is that I don't think cannabis use disorder should be diagnosed by someone who doesn't understand the endocannabinoid system or the nuances of the different cannabinoids. That's just my opinion for now. So the prevalence, we saw in a report in 2019 that approximately 48.2 million US residents aged 12 and older reported using cannabis in the past year, and about 4.3 million of them reported criteria that met the DSM-5 diagnosis, which we'll go through in a couple of slides, for cannabis use disorder. So based on that, it's estimated that cannabis use disorder affects about 10% of users. We also have heard that public health burdens are lower compared to other substance use disorders. So if you look at tobacco dependence, it's about 32%, heroin 23%, cocaine 17%, and alcohol is 15%. We know that cannabis use disorder is primarily associated with Delta-9 THC use. And we see the highest prevalence of cannabis use disorder in North America at about 12.4%. West and Central Africa is the same at 12.4%, followed by North Africa at 4.3%, and then Eastern and Southern Europe, 2.3%. The lowest, anybody want to guess where they might see the lowest prevalence of cannabis use disorder? There are no brownie points or prizes for this. It is Asia. Next slide, please. This was a study, a Columbia University study, examining cannabis use disorder among daily cannabis users. And this was from 2002 to 2016. We saw use in the US decline from the late 70s to 90s and then increase again over the last decade. This study looked at cannabis use disorder among the daily cannabis users. So it was primarily looking at individuals who used cannabis 300 plus days a year. Prevalence decreased significantly among adolescents, about 26%, almost 30% among 18 to 25-year-olds, 37.5% among 26 and older. And this was looking at about 22,651 individuals, again, that were using cannabis 300 plus days a year. The cannabis use rates have remained stable from about 2002 to 2014. We see mostly adolescents will have cannabis use disorder diagnosis versus adults. So those who start in young ages, and I'll show that in the next couple of slides. The risk is really associated with the frequency of use, not just number of days, but weekly users versus daily users are going to more likely meet that criteria for cannabis use disorder. Next slide, please. And so again, that risk factor, the risk goes up in those who are younger than 16 if they start to use this. I see this in practice a lot. I see a lot of concerned parents who will want their teens, adolescents to have a consult with me because they started using cannabis sometimes at the age of 12. Now they're 17. Their use is now affecting their grades, their ability to function. They're, dropping out of school. They have antisocial behavior. So there's a lot of concerned parents out there that when they come to me, want to know whether or not their use could be considered cannabis use disorder. We've also seen that cannabis and tobacco use can increase risks of cannabis use disorder. There's usually around the onset of age, about 15 or 16 is when we'll see the highest risk for those to develop cannabis use disorder. Use before age 18 has been associated with antisocial behavior, polysubstance use, and early school dropout. So we really want to be monitoring this age group. And what I often find when I'm working with these adolescents is that they come to cannabis because they're not sleeping, they're feeling anxious, they may not be very hungry, right? They don't have really good habits in place to deal with life stressors, and they may come to cannabis and find that it helps. And what we're going to talk about in some of the other slides is really around the endocannabinoid system and maybe how the chronic use of cannabis can actually cause a dysfunction in the endocannabinoid system. Again, I think if we're going to be diagnosing someone with cannabis use disorder, we need to really understand the intricacies of the endocannabinoid system. This is the Diagnostic and Statistical Manual of Mental Disorders in their 5th edition. They listed the following risk factors for cannabis use disorder: family history of chemical dependence, a history of conduct disorder or antisocial personality disorder, low socioeconomic status, history of tobacco smoking, abusive family, unpredictable family circumstances, family members who smoke cannabis. I don't know about that one. Poor performance in school, easy to get cannabis, and a drug-tolerant culture. Obviously, the more risk factors, the higher chances of them developing cannabis use disorder or even substance use disorder in general. Next slide, please. We also know that if there's additional mental health diagnoses, there could be an increase in these risk factors. But these are also risk factors, an increase of a diagnosis of cannabis use disorder. There's a possible correlation between post-traumatic stress and cannabis use disorder. Although, interestingly enough, there was a study that came out in, I think it was 2021. It was looking at trends in cannabis use disorder diagnosis in Veteran Health Administration from 2005 to 2019. And what they did is they went back and looked at records and basically saw that there was an increase in cannabis use diagnoses. And the challenge that I have with that is that you're looking at, when you're working in the health system in the medicalization model, often these patients are getting diagnosed with cannabis use disorder based on algorithms that may be in the electronic medical record. So if your patient answers something like, well, yeah, I use cannabis daily, but you're not differentiating between the cannabinoids and medical use or dosages or routes of administration, this electronic medical record may automatically put cannabis use disorder in that patient's medical record. And so, it's based on algorithms, it's not individualized, but what they saw in these veterans was that there were higher rates of cannabis use disorder in males and females. So is that a risk factor? Possibly. Higher in Blacks. So are we talk a lot about racism in healthcare. This is another potential example. And they saw the highest rates of cannabis use disorder diagnosed among those who were under the age of 35. So again, there may be a higher propensity for cannabis use disorder if you're starting the use of cannabis at a younger age. I think we need to do more research on that. There's also increased risk of developing major depressive disorder in heavy cannabis users, especially among adolescents who start using it. So that's like 8.3% higher. I see this. I definitely see this in my practice. I see an increase in depression and anxiety, which I'll talk about in a couple slides. The age of cannabis use may predict emotional processing issues as well as the severity of the major depressive disorder. In one study, they looked at 73 participants between the ages of 16 and 23. 20 of them had major depressive disorder, 20 were non-depressed, low cannabis users, 20 non-depressed frequent cannabis users, and 17 frequent cannabis users with active or recent major depressive disorder. 37 participants met the criteria for major depressive disorder, and 32 were actively experiencing an episode, and 15 were on an SSRI. So there's not only are there risk factors, there's also co-factors that can happen with some of these patients who are using. So we're more likely to see those with psychiatric disorders may also be self-medicating, right? So are they using cannabis to help with their depression and anxiety, and then their use becomes overuse? Again, that's a question I think we need to look at in the research. Next slide, please. Again, those comorbid potential mental health disorders. Again, they looked at one study where they found 7 out of 10 diagnosed with cannabis use disorder also had a additional mental health disorder compared to 4 out of 10 without a cannabis use disorder. So there was a high association with anxiety, PTSD, and personality disorders. The prevalence of generalized anxiety disorders in the US is about 8.9% among those with cannabis use disorder. 12% of individuals with cannabis use disorder also had major depressive disorder, and bipolar and cannabis use incidence was around 20%. The incidence of cannabis use disorder and schizophrenia is around 26.6%. Again, it's higher in the UK and Australia compared to the United States. But again, the question I always have is what's coming first, right? Are they using cannabis to self-treat these symptoms, and then their use becomes problematic because their endocannabinoid system has become dysfunctional? I'd love to see some more research on that. Next slide, please. So according to the DSM-5, this is how they decide about a diagnosis. And again, I don't think that those who are using this manual should use it unless they have had cannabis education. So if you're using cannabis for a minimum of a year with the presence of at least 2 of the following symptoms accompanied by serious impairment of functioning and agitation. And you look at some of these, right, used in larger amounts over a longer period of time than was intended. Well, people can build a tolerance. And again, there are medical patients that are using cannabis who may need to use larger amounts over a longer period of time. But if they're not able to disclose with their providers in a safe way about their medical use, then that could be seen as now they've met one of the criteria. Maybe they've repeatedly tried to stop or lessen the amount of cannabis they've used because they're ashamed of their use and the stigma, and or they don't feel like their healthcare team is supporting them and they want to stop, but it's the only thing that helps their symptoms. Again, this is sort of based in prohibition and stigma. Unusual amounts of time is spent trying to get, use, and or recover from cannabis effects. Well, sometimes prohibition puts us in situations where it is causing us to spend a lot of time to try to get our cannabis because certain cities and counties won't allow it. Having cravings for cannabis, such as thoughts and images, dreams, and perceiving smell because of an obsession with it. Persistent use of cannabis despite negative consequences, such as others wanting to leave the relationship or being left by a partner or friends, poor job performance, criminal charges. Again, I think that's rooted in a lot of the prohibition. And somebody could easily be, given that category when it isn't necessarily appropriate. Using cannabis is more important than other areas of life: jobs, school, hygiene, responsibilities to family members and friends. Using cannabis and taking dangerous risks, such as driving a car. Using cannabis even though the person's aware of the physical and psychological problems, lack of motivation, chronic cough. Builds a tolerance to cannabis, taking larger amounts to get the psychoactive effects experienced when it was first used. Again, we know that people can build a tolerance to the euphoric effects of THC, and sometimes they are using the THC as a mood elevator. So it doesn't necessarily mean that they have a disorder. They just have built a tolerance. We see this with gabapentin. We see this with opioids. We don't necessarily give somebody a diagnosis of opioid use disorder because they have built a tolerance. And cannabis, if it's used to halt the symptoms of withdrawal. Well, again, this is really focusing on THC, right? It's not looking at, when you'll see in a couple of slides, how we might be using some other cannabinoids to help with the symptoms of withdrawal. This diagnosis, cannabis use disorder, can actually be made 1 month if the user's been consuming it daily or almost daily. Next slide. And there are 3 different categories in which you can be placed with a cannabis use disorder. There's mild, moderate, and severe. You only need 2 of those criteria on the last slide to be considered a mild cannabis use disorder. So 2 to 3. For the moderate, the person must have 4 or 5 of the above symptoms. And for severe, they're going to exhibit 6 or more of the symptoms noted in the DSM-5. Next slide, please. And unfortunately, this is our cannabis use disorder test that is often used to help diagnose or to get a patient to answer and use as whether or not they may have a cannabis use disorder. And I think that this is, again, problematic. It's not taking into account any kind of medical use or any other types of cannabinoids. It's really just generalizing cannabis and probably just THC. And I know this slide is tiny and probably hard to read for some of you, but the first question is, how often do you use cannabis? Well, for a lot of us, if we're using cannabis as a wellness or as a medicine, we're using it daily, right? So you automatically get 4 points if you're using it 4 or more times a week. All you need a score of is 8 points to indicate a possible hazard cannabis use, and 12 or more would indicate cannabis use disorder. So again, how many hours were you stoned on a typical day when you were using cannabis? I mean, what does that even mean? How often during the last 6 months did you find that you were not able to stop using cannabis once you started? How often during the last 6 months did you fail to do what was normally expected you because of using cannabis? Well, what about if actually helped us to do the things we needed to do, right? And we didn't have access to it. How often in the past 6 months have you devoted a great deal of your time to getting, using, or recovering from cannabis? How often during the last 6 months have you had a problem with your memory or concentration after using cannabis? How often do you use cannabis in situations that could be physically hazardous, such as driving, operating machinery, or caring for children? And have you ever thought about cutting down or stopping the use of your cannabis? Unfortunately, this tool is really, I think it's poorly designed and doesn't meet the needs of our patients and can often lead to overdiagnosis. Next slide, please. There's no consensus on screening data. So that tool that I just showed, while it's used widely, isn't necessarily recommended. The U.S. Preventative Service Task Force recommends screening adults greater than 18 for illicit drug use, pregnant and postpartum people, and adolescents between the ages of 12 and 17 when they're in the primary care setting. So when they go to see for their checkups. Screening high-risk populations, such as patients with psychiatric or forensic history, is considered good clinical practice. And a systematic review of screening measures in emergency departments found that a single screening question in the past year, how often have you used cannabis, was as effective as multi-item measures. Now, let me tell you, in the medicalization world, and I am in that world, we often are trying to find these universal precautions or questions that we can use, 1 or 2 questions, to try to help screen patients or lead us to, other screening agents that may help us go down and to dive more into, does this patient have a substance use disorder, a cannabis use disorder, opioid, alcohol use disorder? I don't know that question in the past year, how often have you used cannabis? I know if I answered it, they would automatically put me into a bucket that would be inappropriate. So again, concerning about how we approach this in general. Next slide, please. What we really need to be doing, not only just in how we interact with our patients, if we're going to be assessing for cannabis use disorder or any kind of substance use disorder, is not only assessing the frequency, but the type. Are they using CBD, CBG? Are they using THC and CBD? What kind of route are they using? What else is in that cannabinoid profile? Is it, what are the terpenes like in it? And we should be assessing for comorbid mental health challenges. We should be assessing for possible side effects like dry eyes, dry mouth, tachycardia, anxiety, constipation, psychosis, and really asking about their social and physical histories, and not just how many times in the past year have you used cannabis. Next slide, please. If we do identify that somebody is at possible risk for cannabis use disorder or has cannabis use disorder, we want to talk about helping them come off of it if we feel like their use has become problematic. So some of the examples I will give is, I have had adolescents, like I said, where the parents have come to me and they're concerned about their kids' use. It's because it's predominantly THC. I've had some adolescents who are using around 450 to 500 milligrams of THC daily. And often what happens is they're using that because, again, they started using it at a younger age. It was helping their anxiety and depression. Now they've gone and had this bidirectional, biphasic effect where it's probably making their anxiety and depression worse. We do have some good data that shows you can actually cause the cannabinoid 1 receptors to become dysfunctional and hide within the cell. We have that, what we call that downregulation. In those situations, one of the first things I'll do is recommend that we get CBD on board. Because it's going to be, if we're going to get this adolescent or this person who has possible cannabis use disorder off or reduce their dose, they're probably going to have some withdrawals. And we currently don't really have any FDA-approved measures to manage cannabis use disorder or cannabis, withdrawals. There's a little bit of data that gabapentin might be effective in treating withdrawal effects, particularly associated with Delta-9. This was a preclinical study, so It decreased some of those somatic withdrawals in mice, the tremors and head shakes. And again, I don't know that I want to be using gabapentin necessarily to replace THC, but it is something that is potentially out there as an option. Next slide. But withdrawals are very individualized, and sometimes they're having withdrawals from the cannabis because they are also having side effects from their cannabis, right? Not just the depression and anxiety, but sometimes we'll see cannabinoid hyperemesis syndrome. And in those cases, we really do want to have them to stop as quickly as possible, because cannabinoid hyperemesis syndrome can get so severe that they can end up severely dehydrated and have to go to the emergency department. So if they're not experiencing something like that, where you're concerned about their health and well-being, I always recommend that there's a weaning process when you're coming off, because the withdrawals sometimes are delayed. Just remember, cannabinoids can last in the system for 5 to 13 days if you're using it daily and consistently. So after about 24, 48, 72 hours, when you've stopped, you'll start to see those withdrawals actually are delayed. They don't happen the first day or two. And then some people will start to experience flu-like symptoms, diarrhea, achy body, achy joints, difficulty sleeping, irritability, depression, anxiety. It's not usually severe, but it can be uncomfortable, and it can certainly affect quality of life. Again, if they're on multiple substances, sorry, guys, and not just THC, maybe they're drinking alcohol, maybe they're on opioids. Sometimes it's hard to determine if they're withdrawing from all of them at the same time, which one's causing which symptom. I often will recommend treating the withdrawals. So if there's no sense of urgency for them to get off of it, and they're really struggling, I might have them slow down on how quickly they're weaning down on some of these substances, whether that's THC or opioids, for example. So current treatment, really hydration, exercise, sleep, hygiene, good nutrition. They might want to be doing some cognitive therapy for it. Again, gabapentin may show some promise. If you look at the next slide, we may find that it can actually help. Again, the CB1 receptors are downregulated in cannabis use disorder. We see this in, again, with chronic THC use. So do we want to be using gabapentin for that? Maybe, maybe not. There's, maybe it's on my next slide. Yeah, sorry, it's on the next slide. We know, you can go back though, Tim. Thank you. Because again, I just want to remind everybody about the endocannabinoid system and the reward system, that CB1 activation can activate the reward system. So that dopamine indirectly. There are no CB1 receptors in the dopaminergic neurons in the midbrain. So THC is not consistently self-administered among rodents. This isn't a study, but CB1 agonists were. In fact, CB1 agonists like nabilone, so that's a synthetic THC FDA-approved drug, may play a role in cannabis dependence as they decrease cannabis use. Dopamine receptor availability is not affected by chronic THC use, but users may have decreased ability to synthesize dopamine and lower dopamine transporter availability. So again, we see this where patients who may be using cannabis as a medicine, right? Think about our Parkinson's patients who actually are trying to use THC to increase the dopamine in their body, right? And help them with their symptoms. Over time, that THC can actually decrease their body's ability to produce dopamine. So heavy chronic use may not be, they need to be followed and managed and evaluated and reevaluated to make sure that their use is still appropriate. Sorry, guys. Okay, next slide, please. So again, here's the gabapentin. And this is just really one of the only pharmacological options that we have outside of CBD to possibly manage cannabis use disorder. There were some preclinical trials, again, to show that THC can increase glutamate levels, and chronic cannabis use can result in decreased glutamate levels. Gabapentin can modulate our GABA and glutamate transmission. So they looked at single doses of 900 to 1200 milligrams of gabapentin in healthy individuals and found that it was significantly increasing GABA. So this may be a short-term solution for some patients who really are struggling with the withdrawals from coming off THC. Most of these studies have been pretty low participation, small dose or small study amounts of individuals, but I have my own challenges with GABA, so I don't know. But monitor your patient. If you feel like they're doing okay with the withdrawals, then maybe they won't need it. Next slide, please. But then, there's CBD, and CBD has been shown to be non-addictive and thought to decrease the rewarding effects of delta-9 THC. It's often why you see people recommending CBD and THC together. There was a study of 17 non-daily cannabis user volunteers, and they took 8 milligrams of THC and 10 milligrams of CBD with that 8 milligrams of THC. They did a functional MRI to examine resting brain state. And what they found was that CBD restored the THC-induced disruption of the salience network, which could treat disorders such as psychosis and addiction. And we are starting to see more research come out around how CBD can help with things like psychosis and anxiety and even depression. It's always higher doses of CBD compared to lower doses of THC. I'm seeing studies now looking at anywhere from 200 milligrams of CBD to as much as 900 milligrams of CBD. And of course, the challenge with that is it's cost prohibitive for our patients. Most of our patients are not going to be using those amounts, at least if they're, getting it over the counter. So we want to be really mindful about whether or not we can offer this to them, because 400 to 800 milligrams of CBD a day to help manage cannabis use disorder versus gabapentin, which is probably going to be, $5 to $10 a month. Sometimes patients are really put in positions where they have to make decisions because it's financial. It's an affordability issue versus what's really best for them. Next slide, please. This was a case study where they were looking at a 16-year-old with multiple psychiatric disorders: anxiety, major depressive disorder, social phobia disorder, multiple substance use disorder, narcissistic personality disorder. They used 300 milligrams twice a day of CBD, so a total of 600 milligrams a day over 6 months. And the patient had improvement in all psychiatric disorders, stopped the antidepressants and THC use without any notable withdrawal symptoms. The other study was a phase 2A double-blind randomized placebo-controlled study. It was a 4-week trial looking at 200, 400, and 8 milligrams of a synthetic 99% purified CBD, and then they had a placebo group. They eliminated the 200 milligram dose pretty quickly because they found out early on it was not an effective dose. The 400 and 800 milligrams were both found to be more effective than placebo at reducing cannabis use, though 400 was marginally more effective than 800. So they didn't see a big difference between those two dosages. Again, this is when I'm working with patients who I think have a cannabis use disorder or a high amount of THC use. I want them on high doses of CBD as well. And often I will see them reduce their THC use over time. Next slide, please. And this is just the last slide before Tim gets into cannabis use disorder in the media. And I think he'll riff a lot on what I've talked about here today. This is just the other option that we have for non-pharmacological ways to treat cannabis use disorder are through cognitive therapies. And a lot of times, again, in these adolescents that have likely, started to use cannabis early on and have become dependent on it to help them with their anxiety and depression. If you're taking that away, they are going to need something to help them deal with their anxiety and depression. And cognitive therapies can be a great way for them to work through a lot of their trauma and other issues, because they're looking for that thing that's going to work for them quickly. And unfortunately, once we take that away, we really need to make sure that they have other tools that allow them to be able to use it in a way that, doesn't have them go back to the cannabis if that was causing problems in their life. So Tim, I'm going to put it over to you now so you can talk about cannabis use and that narrative in the media.
Thank you, Eloise. I want to have some time at the end of the hour, so I'm going to move kind of quickly through this material. But if you do have any questions, don't hesitate to throw it into the chat. So let's start with this number, 9%. So an estimated 9% of cannabis users have some type of cannabis dependence or cannabis use disorder. This number is so ubiquitous, it's nearly canonical. It's not even questioned any longer, and it's been pretty stable over many decades. So where does this number come from? How is it determined? The 9% number comes from the National Survey on Drug Use and Health. This is conducted annually by the Substance Abuse and Mental Health Services Administration. It's a branch of the U.S. Department of Health and Human Service. So the survey that they do, it's a survey that it's a nationally representative data on the use of tobacco and alcohol and illicit drugs, on substance use disorders, including cannabis use disorder, whether a person is receiving substance use treatment, and other data points that provide information about mental health issues, mental health services, all among U.S. citizens ages 12 and older. So the Substance Abuse and Mental Health Services Administration has conducted this survey since 1971. And what they do is they randomly select about 70,000 people to participate, and then they extrapolate those results to the national population. So just to make sure that everyone knows what the national population is, in 2021, it was about 332 million. So the data that they collect is intended to enable researchers and clinicians and policymakers and even the general public to better understand and improve the nation's behavioral health. One really interesting fact about this survey is that the first two, 1971 and 1972, were completed by the National Commission on Marijuana and Drug Abuse. And this, of course, was the Schaefer Commission. And they concluded their work in 1972, and they produced a report called Marijuana: Signal of Misunderstanding. Many of you have probably read that or are familiar with it. It recommended decriminalization, and of course, it was promptly ignored by the Nixon administration and by every subsequent administration up until quite recently. Since 2018, there's another data set that researchers now use to cross-check the data from the Substance Abuse and Mental Health Services Administration. So the Centers for Medicare and Medicaid Services, and you'll see this written as CMS, has now released 3 publications of what they call the Transformed Medicaid Statistical Information System. And the acronym that you'll see for that is T-MSIS, so TMSIS. And it's based on what they call the Medicaid Substance Use Disorder Data Book. And the data includes a number of Medicaid beneficiaries. So we're talking about low-income Americans here who are treated for substance use disorder, and then also the services that they received. The data book is now published annually. And again, we have 3 years of data from that group. And it also intends to help policymakers and researchers and other stakeholders better understand where to focus drug prevention and treatment efforts. So there's a study that was completed at Johns Hopkins, and it concluded that the CMS numbers suggest a higher national prevalence of substance use disorders than that represented by the national surveys completed by the Substance Abuse and Mental Health Services Administration. So what the CMS is suggesting is that generally there's a greater burden of these conditions of substance use disorders in the US than what was previously reported by the national surveys. I think it's logical to simply suggest that there exists a correlation between low-income patients and substance use disorder. It's not unreasonable to suggest that the burdens and stress of poverty might contribute to substance abuse. But I think it's also reasonable to suggest that clinicians working with low-income Americans will diagnose these patients with substance use disorders more frequently than they would wealthy patient groups. In fact, there is a significant and long-standing body of research that suggests that provider and institutional bias and discrimination are drivers of racial and economic disparities in health, and this contributes to differences in diagnosis and prognosis and treatment decisions. So it's arguable that low-income patients and patients of color are being diagnosed with substance use disorder more frequently than other patient groups. And this is always in the back of my mind now when I see studies, for example, that suggest a recent increase of things like cannabis use disorder, for example, among young Black male Americans. So the data in the Medicaid Substance Use Disorder Data Book includes the number of participants in treatment for substance abuse. Again, this is the data that suggests the problem of substance use disorder generally is more prevalent than what we previously thought. I want to take this opportunity to remind everyone that in 2017, the journal Substance Use and Misuse reported that over half of all minors in drug treatment for cannabis use are mandated to attend by the criminal justice system. So it's not necessarily abuse. I mean, they could have been caught once. They could have used cannabis once and got sent into the criminal justice system and tagged with some kind of dependence. Also, it's interesting to note that there has been a sharp decline of mandated treatment for minors in states that have legalized cannabis, and there's a corresponding decline in the number of reported prevalence of cannabis use disorder. Now, one likely reason is because declining cannabis admission rates to mandatory treatment are typically they're correlated with changes in cannabis law enforcement and sentencing. All right, so that's just a little bit of background to explain why we see these specific numbers referenced in media articles and also in the medical literature. So let's talk about how cannabis use disorder specifically is treated in the popular media. Frankly, I don't see a lot of articles that directly address cannabis use disorder by itself. They do seem to be growing in number, but typically you'll see references to things like cannabis addiction, especially in the context of cannabis addiction replacing alcohol use. You'll see lots of teen use stories about how to treat cannabis addiction, and more frequently, a conflation of cannabis use disorder or dependence and some second related adverse effect. And your perception of how cannabis use disorder is represented in the media will likely depend on the media that you pay attention to and the data that those stories emphasize. And so we're going to look at some articles in the media, but I also want to look at some studies because the study data is often the catalyst for the articles that we see in outlets like CNN or Newsweek and other major media outlets. And the details of these studies will also provide some explanation about why we can find multiple media articles that present dramatically different conclusions about similar subjects. So let's start with this one. This is a study that was published by the Centers for Disease Control and Prevention, the CDC, looking at treatment admissions for minors. And this was a period from 2008 to 2017. So we're looking at a period slightly before adult use legalization that continues through widespread medical and adult use cannabis legalization. Now, the data that this study examined was for substance use disorder treatment admissions among adolescents 12 to 17. And it was taken from the treatment episode data set and colon admissions. And so this is abbreviated. Sometimes you'll see this as TEDS-A. This is a national compilation of admissions to publicly funded substance abuse treatment facilities. So they're looking directly at admission rates at treatment centers. Now, the blue states that you see on this map, the blue states are those with declining admissions, so fewer adolescents who are being admitted for cannabis use disorder. The darker the blue, the larger the decline in treatment admissions. The map clearly shows that adolescent treatment admissions for cannabis declined in most states over this study period. In fact, the mean annual admission rate for all states declined over the study period by nearly half. So from 60 admissions per 10,000 adolescents in 2008 to about 30 in 2017. Admission rates increased over the study period in only 7 states, 6 of which, and the exception is North Dakota, had already had relatively low admission rates to begin with. And those are the states that are colored in the, I guess it's kind of a light yellow or light orange. So the CDC concluded that legalization, quote, does not appear to correspond to treatment admission rates, and that notably 7 of 8 states with recreational legalization during the study period fall into the class with the steepest level of admissions decline, end quote. Now, I don't want you to think that the CDC is out there stumping for cannabis. These are not the results that they expected to find. They also provide a lot of caveats for these results. They suggest that the causes for the decline might be due to changes in attitudes towards cannabis, differences among states and socioeconomic status of those diagnosed with CUD, and also whether there was available treatment and health insurance. And this was their final warning in the report. They said, quote, "Whatever the causes of the observed patterns, however, this research suggests that a precipitous national decline in adolescent treatment admissions, particularly in states legalizing recreational marijuana use, is occurring simultaneously with a period of increasing permissiveness, decreasing perception of harm, increasing adult use regarding marijuana. These trends indicate the need for sustained vigilance in the prevention and treatment of youth cannabis use disorder during this period of expanding marijuana legalization," end quote. So, of course, the cannabis industry saw this and published articles about it. This is one example. This is from Leafly. And we'll see this kind of thing in pro-cannabis media, right? Amid legalization, teen hospitalizations for pot down 50%, the CDC finds. But then we have this study. This was published in the Journal of the American Medical Association that looked at a similar time frame, but published very different conclusions about adolescent cannabis use disorder. They use self-reported survey data from the National Survey on Drug Use and Health. And remember that this is the data collected by the Substance Abuse and Mental Health Services Administration. And they've been collecting that data for 50 years. And this data that this study collected was from 2008 to 2016. So roughly the same period. This study looked at past month cannabis use, past month frequent cannabis use, past month frequent use among past month users, that's my favorite one, past year cannabis use disorder, and past year cannabis use disorder among past year users. And they concluded that there was actually a small increase in cannabis use disorder among adolescent users, and then larger increases in both frequency and of use and cannabis use disorder among adults after legalization of adult use cannabis. So we can see that this study and the study by the CDC came to two very different conclusions simply by looking at two different data sets. The CDC, and recall that their study looked directly at admission rates at treatment centers. They noted a quote, precipitous national decline in adolescent treatment admissions, end quote, for CUD. The study published in the Journal of American Medical Association, and recall they were looking at self-reported data. They suggested a small increase among this same age group. And predictably, here's an example of an article that's based on the study that was published in JAMA. A troubling new study shows that legalizing marijuana is linked with an increase in problematic pot use among teens. So we're beginning to see how consumers of this news can draw very different opinions and conclusions. And both audiences can feel like they're very well informed, right? I got one audience looking at something from the CDC, one audience looking at something that's published in JAMA. So two audiences that are fairly fixed in their opinions about whether legalization is adversely or positively impacting adolescent use. Now, more frequently, you are likely to see articles that continue to associate cannabis use and cannabis use disorder with some other adverse effect or condition. And usually the narrative is that heavy use of cannabis or use of high potency cannabis can cause the second condition. And very frequently, the second condition is some type of psychosis. And it's usually schizophrenia that we see in the press, because schizophrenia is frightening and it sells newspapers. So this is actually a study from 2021 that CNN wrote about that suggests that there is an increase in the occurrences of schizophrenia in Denmark, and it can be correlated to cannabis use disorder, increases in frequency of cannabis use, and increases in potency of cannabis. When you read this study, it actually looks like a well-designed study. These researchers used information from Denmark's Psychiatric Central Research Register. And this includes all inpatient and treatment at psychiatric departments since 1969. And it also includes all outpatient treatment in psychiatric departments since 1995. They also supplemented the data with data from the National Patient Register, which contains data on inpatient and outpatient treatment at all general or non-psychiatric departments. And this is how they determined the number of occurrences of cannabis use disorder. They also accounted for a large number of confounding factors, things like tobacco use and other substance use disorders, substance use disorder in parents, socioeconomic status, mental health issues, and so forth. So it does look like it's a reasonably good study, but I do want to point out a couple of important limiting factors in the study. First, the study occurred in Denmark prior to any cannabis legalization. So all cannabis in the country during the study was from the illicit market. Second, the study didn't include any information about types of potency of cannabis used by anyone in the study population. So how they're correlating schizophrenia with higher potencies of cannabis is unclear to me, because they don't know the potency of the cannabis that these participants were using. And then finally, it doesn't prove causation. This is another occurrence of demonstrating correlation and not causation. And we'll talk a little bit more about this shortly. So here's another correlation with cannabis use disorder. This was a study that suggests an increasing trend of heart attack hospitalizations with concurrent cannabis use disorder. The study states that the most significant determinants of CUD in young heart attack patients were the following. They were 18 to 34 years old, they were male, they were African American, and they had psychiatric conditions. So right away, I'm skeptical, right? I'm skeptical of these results because the group with the most significant correlation are young Black males, which leads me to think about, number one, it's pretty clearly demonstrated that usage rates among young Black Americans is no different than those of other groups. And number two, how institutional bias and discrimination are drivers of racial disparities in health, and how those disparities contribute to racial differences in diagnosis and in treatment decisions. Furthermore, the study was observational. It didn't control for use of other substances such as tobacco and alcohol and cocaine and other substances of abuse. So the data certainly does not demonstrate causation. We've done an entire Radicle Community webinar on cannabis and cardiovascular disease. So I invite you to watch that webinar. You can see it for free on our Radicle Health YouTube channel. And then there's Fox News. So there's really very little value here. It's clickbait, and it really just serves to confirm existing bias. But I'm including this type of story here because it's a fairly typical strategy. And it's not just Fox News, it's other media outlets also. And the strategy is this. The story will briefly allude to some study, regardless of the integrity or quality of the study. And this provides a veneer of supporting science. And then the story launches into a straw man argument. And this particular story, the specific straw man argument, refers to a really good example of the most damning type of anti-cannabis study. So the researchers in this study, and the study is actually part of the screenshot in the top left corner, these researchers stated that 30 to 50% of all psychosis cases in Europe are due to cannabis exposure, especially exposure to high potency THC products. Now, I probably don't need to tell you this, but this is an incredibly speculative and highly questionable hypothesis. But remember, most readers, probably most Fox News readers, they're not going to closely read the study. They may not read the study at all. A lot of people might simply see the publication that was published in the British Lancet and this sounds authoritative. So they might just take it at face value. But essentially, these researchers are correlating cannabis use with psychosis and cannabis use disorder, but they're not demonstrating any kind of causation in any way whatsoever. Now, there are a lot of reasons why cannabis might be correlated with psychosis. It's well established that people with psychiatric illness typically use all intoxicants at greater rates than do the general public. So people admitted to institutions for first episode psychosis are more likely to consume cannabis than those in the general population. The same group of patients might also be self-medicating with cannabis. Eloise mentioned this earlier. They might be genetically predisposed to cannabis use, just as they're genetically predisposed to psychosis. None of these factors indicates causation. And the researchers actually in the study, they do list these as limitations, but you have to read all the way to the end of the paper to actually see these. All right, so we've talked about kids and cannabis in the media. What's the other vulnerable patient population that facilitates the most hand-wringing in the context of cannabis? Of course, it's pregnant women and lactating women. So this is a study that looked at pregnant women in 35 US states, determined what percentage of prenatal hospitalizations were associated with cannabis use disorder. And the study stated that cannabis use disorder increased substantially between 2010 and 2018. And their sample included nearly 21 million hospitalizations of individuals who were pregnant. During the study period, they found a total of nearly 250,000 hospitalizations that involved cannabis use disorder. So roughly about 1.2% of the patients in the study. The study stated that younger patients and patients receiving Medicaid, so low-income patients, were overrepresented in hospitalizations with cannabis use disorder. So low-income patients are using cannabis during pregnancy more frequently than higher-income patients, or wealthier patients are diagnosed with cannabis use disorder less frequently than poorer patients. Furthermore, out of the 250,000 patients diagnosed with cannabis use disorder, half of these diagnoses occurred during hospitalization. So any cannabis use might have been coded as cannabis use disorder while these patients were in the hospital. And you can see this is the type of article that we typically see in the press regarding cannabis use and pregnancy. So we've been talking a little bit about correlation and causation. I want to stop and remind everyone, correlation does not equal causation. If you look long enough, there are lots of correlations that can be drawn between many things. And when you have 10 minutes, have a look at the website Spurious Correlations, for example, of how easy it is to draw correlations between two completely unrelated phenomena, such as the number of people who drowned by falling into a pool and the films that Nicolas Cage appears in. So we want to be really careful about drawing associations or correlations versus saying that one thing causes another. Now, I would be remiss if I didn't point out that it wasn't too long ago when there were people in the industry who were highly suspicious of even the concept of cannabis use disorder. For example, this is an article by Paul Armentano. He's the deputy director of NORML. If you don't know Paul's work, you should. It's from November 2019. Paul, in his article, he refers to the diagnosis as so-called cannabis use disorder. He puts the diagnosis in quotes as if it's simply another highly dubious constructive narrative in a long list of highly dubious constructive narratives by cannabis prohibitionists. Of course, I respect Paul, and the industry owes him a great debt for his contributions. And I'm willing to bet that Paul has also likely come around a bit on this topic. But nevertheless, he's not alone in his distrust. And I think possibly what's happening here is that we are beginning to see two distinct, but not necessarily contradictory narratives that are developing, well, one established, one developing, that describes cannabis use, especially daily or frequent use. And again, one narrative is quite old, and the other is perhaps has been developing over, maybe the past 5 to 10 years. Now, the first narrative, the old narrative, is that there are some people, and there might not be many, but they do exist, who should not use cannabis. And some subset of this group shouldn't use cannabis because they've developed a dependence and they will experience adverse effects that are a direct result of their cannabis use. This narrative is firmly part of the well-established cannabis is a drug of abuse paradigm. In this paradigm, the thought is we need to mitigate the harms of cannabis use, especially in vulnerable patient populations. But there is a second narrative developing as well. Many people are beginning to incorporate cannabinoids into their daily health routine in the same way that they might take a daily vitamin supplement. The harm reduction model doesn't really apply here because there really is no harm being done. The cannabinoids in this patient group are actually serving to improve or even enrich the lives of patients or other consumers, even if they're using cannabinoids on a daily basis. So that brings me to this study and these articles, and these will be the last couple that we review today. So this is a study, it came out of the University of Colorado and the University of Minnesota. And last year, the same team did a study that suggested that legal cannabis states were seeing increases in cannabis use in adults. But what they really wanted to know is, are there harmful consequences to increases in cannabis use in adults who are using legal cannabis products? So we're seeing increases of cannabis use in adults. Should we be concerned? So these researchers used long-term data on twins to assess the impacts of cannabis legalization. And they established 23 criteria, and they coined them psychological dysfunction criteria. And they included things like substance use disorder, including cannabis use disorder, but other things like financial difficulties. They included mental health distress, community disengagement, relationship issues, those kinds of things. And the study included about 4,000 people, and about 40% of those people in the study lived in a legal cannabis state. And here's what they found. They didn't find anything. When one of the members of the research team was interviewed, this is what she said. She said, quote, obviously the cannabis use increases, but we didn't see an increase in cannabis use disorder, which is a little surprising. We didn't really see changes in how much people were drinking or using tobacco, no large personality or workplace or IQ differences or anything like that, end quote. So the study concluded that people in legal states did not report using illegal drugs at higher rates. Researchers also didn't find a link between cannabis legalization and psychotic behavior. They did find one result that I thought was somewhat interesting. People living in a state where adult use is illegal reported higher rates of alcohol use disorder, and more specifically, one symptom of alcohol use disorder, and that was they were more likely to report using alcohol in situations that were dangerous or harmful, such as driving drunk. Which brings me to this article. This was published in the summer of 2021. So these authors suggest that if there are few adverse effects related to cannabis use, and most of them probably won't experience them, if there are multiple benefits, and if the evidence of any addictive or dependent properties are scant at best, is cannabis dependence really all that harmful? So they ask, and this is a quote from the paper, they say, if a person can use cannabis daily and it doesn't negatively affect their ability to function as a valuable member of society, and they have access to a legal supply, where is the problem exactly, end quote. I think we should also ask, and I'm gonna, Eloise mentioned this earlier, and this was something that she was emphasizing, we should be asking, are cannabis users, especially people of color and low-income patients, are they being diagnosed with cannabis use disorder incorrectly by clinicians who know very little about cannabis and cannabis use? So I want to end with this, and I know we're a little bit past the hour. We'll stay on a little bit if you have any questions or comments, but I want to end with this. Cannabis use disorder exists. People can have problematic cannabis use. Clinicians should identify problematic use, and they should help that small percentage of patients mitigate their use. And I don't believe that the harm reduction paradigm can fully encapsulate the experience of many other cannabis users. I think that we're starting to see another paradigm of cannabis use, and that paradigm includes, it's a move away from the idea that cannabis is a drug of abuse, but rather it's becoming part of a wellness paradigm. And it's one in which I think consumers and patients are using cannabis to enrich their lives and possibly increase our health spans. So I thank you for indulging us this evening and for attending. It's great to see everyone back in the Radicle Community webinars. We're happy to take any questions. I think, Eloise, I think I saw you moving through some of the questions in the chat. I did notice a couple of people who joined quite late. We are recording this webinar, and we will be putting it up onto our Radicle Health channel on YouTube. So if you have any questions, feel free to put them in the chat, or if you are brave and bold, go ahead and take yourself off mute.